Ladies and gentlemen, a very good evening to you all. Welcome to this BRACO webinar on advances in echocardiography. On behalf of Dr. Caroline Bleakley, who sends her apologies for not being with us this evening due to unexpected inconvenience, I thank all of you for joining us today. Dr. Bleakley would have loved to be with us tonight, and I'm sure she will join us next time. I thank her for the great work she did in preparing this course. My name is Jérôme Puginier. I've been working on contrast-enhanced ultrasound since the early 90s, first as a research scientist, and more now on educational projects. It will be my pleasure to guide you through today's program and to introduce our three marvelous speakers tonight. But before this, I'd like to warmly thank BRACO UK for the great contribution to education in the field of echocardiography. And after last year's webinar, we were asked by many of you to treat new topics, like, for instance, the role of echocardiography in cardio-oncology, to discuss new cases, new clinical cases, and to receive more practical advices. So it's with your input, the input of your community, that we built tonight's program, which is endorsed by the British Society of Echocardiography. Thank you, the BSc, for your support, and you will get 1 point of credit. I have to inform you, I must inform you that the webinar will be recorded and that it will be later on published online, so it will happen in the upcoming weeks. Please use the Q&A button at the top of your screen to ask your questions during the lecture, if this is a burning question. Otherwise, at the end, during the dedicated Q&A session. The first lecture, the role of echocardiography in cardiology, cardiac oncology, will be presented by Dr. Rebecca Dobson. Rebecca is a consultant cardiologist at Liverpool Heart and Chest Hospital. She is an imaging cardiologist and has a special interest in cardio-oncology. She runs the regional cardio-oncology service, and she is particularly interested in cardiotoxicity and carcinoid heart disease. She co-authored the 2021 BSc BCOS Cardio-Oncology ECHO guidelines, and she is passionate about collaborating and sharing expertise and experience with others. Thank you very much, Rebecca, for your engagement. And now the floor is yours.
Okay, good evening, everyone. Hi, thanks for having me. I'm Rebecca Dobson. As Jérôme said, I'm a cardio-oncology consultant up in Liverpool. And I've been asked tonight to talk about a few different things, but primarily the role of echocardiography in cardio-oncology. So I'm going to start by giving a little bit of context to cardio-oncology and explain why it's becoming increasingly important within cardiology. And then I'm going to move on to talk about the role of echo in decision-making process within cardio-oncology. And finally, I'm going to touch upon the experience I've had in setting up a cardio-oncology service. So just to give a little bit of context first, it's important to say that cardio-oncology is not all about cancer within the heart. In fact, the patients that I treat, very few of them have cancer in their heart. And actually, we know that the incidence of cancer globally is increasing. This map here shows the relative changes in cancer incidence from 2005 to 2015. And you can see that in all but a very few areas, the numbers have risen. And on a global scale, the incidence of cancer has increased by a third, so 33% in the last 15 years. And this is thought to be due to a combination of an aging population and also population growth. But it's not all bad news. So not only are more people developing cancer, but happily more people are surviving their cancer as well. And it's estimated that survival will continue to increase, with about 20 million cancer survivors in America alone by 2026. And closer to home, we're seeing a similar picture. So cancer survival in the UK has doubled in the last 40 years. So people who in the past didn't survive their cancer didn't live long enough to develop the complications or the cardiac complications from their treatment. So therefore now the specialty of cardio-oncology has been born. And this, in a nutshell, is there to prevent, detect, monitor and treat cardiac complications in cancer patients. And it covers both the impact or the effect of cancer on the heart, but also the effect of the heart on cancer and its potential treatment. Now, when I first started setting up the cardio-oncology service, I remember talking to a large group of oncologists, and it was almost like there was a divide down the middle of the room. There was half the audience were desperate for some cardiology input and help with their patients, and the other half of the room sort of sat back with their arms folded as if to say, you know, what role could a cardiologist have with an oncology patient, and why are you telling me what to do with my patients? And I think this slide or this paper actually quite nicely illustrates the potential impact of a cardio-oncologist. Certainly, a cardio-oncologist's role is not to tell an oncologist what to do with their patients. I see my role as being there to facilitate safe anti-cancer therapy from a cardiac perspective. So the authors of this paper split the cancer population into 3 different distinct groups based upon cancer mortality rate and cardiovascular disease mortality rate. So you can see group 1 in the top row here. These patients unfortunately have a very high cancer mortality rate, so 70 to 90%. And actually, it doesn't really matter what a cardiologist does with that group of patients. It's very unlikely that you're going to have any significant impact there, because those patients are going to follow the natural trajectory of their cancer and most likely succumb to their cancer. The second group of patients, you can see, have a slightly lower cancer mortality rate, so 40 to 60%, with a slightly higher cardiovascular disease mortality rate. So in this patient group, you can see perhaps there is a role for a cardiologist to get involved. But it's the third patient group, this bottom group here, where you can see the mortality rate from cancer is around the same as the mortality rate from cardiovascular disease. So it's this patient group where it's really important we address cardiovascular issues, be them pre-existing or issues that develop during treatment. It's really important that we address them and treat them, because there's no point curing someone of their cancer if they're then going to succumb to a cardiovascular illness either during or very closely after their treatment. So in terms of what those cancer types are, the authors then split them into different groups here. So you can see these graphs are showing you the mortality rates from cancer in the black line or cardiovascular disease in the red line. So all of these patients who are in that third group of patients, you can see they have similar cardiovascular disease mortality rates and cancer mortality rates. And in some patient groups, for example, thyroid cancer, testicular cancer, prostate cancer, you're actually more likely to die from cardiovascular disease than you are from your cancer. So like I say, it's this patient group that takes up primarily a lot of my time. And I feel that there's a real opportunity there for the cardio-oncologist to make a real difference to the patient. Now, in terms of what we're looking for in terms of cardiotoxicity, I thought it was important to mention that we're not just talking about cardiac dysfunction. So I know tonight we're obviously talking about echo and we're mainly talking about cardiac dysfunction and picking that up with echo. But the role of the cardio-oncologist is to identify and treat in a timely fashion all of these different cardiotoxicities. So that might be cardiac dysfunction, which is usually or primarily caused by the anthracyclines or anti-HER2 therapies like Herceptin. But we also have to deal with cardiac arrhythmias or QT prolongation, hypertension, vascular toxicity, so acute coronary syndromes, coronary artery spasm, and then of course the increasing myocarditis that we're seeing with checkpoint inhibitors. So it's a real broad subspecialty of cardiology, and actually involves almost every different aspect of cardiology in terms of picking up the breadth of cardiotoxicity. Okay, so I'm going to now talk a bit about how important echo is in the decision-making process for cardio-oncology patients. My background is in imaging, so I trained as an imaging consultant with a special interest in echo, and I can't overstate how important high-quality echo is in terms of cardio-oncology. And this is reflected in this survey, which was, I think it was last year. And this is data from 104 different centres from 35 different countries. So it's a big survey. And they asked, how do you detect and monitor for cardiotoxicity in your hospital? And you can see there that the majority of centres use echo with a few other things, with a few other imaging modalities and perhaps biomarkers in selected cases. But primarily it's echo. You can see the green, the blue and the yellow is all echo. In terms of if a significant decrease to ejection fraction is observed, how important is the echo in making that decision? And you can see there that almost 60% of centres will use the echo to confirm a diagnosis of cardiotoxicity. So really this just highlights how important or what such a pivotal role echocardiography plays. And I think that's for several reasons. So echo is widely available, it's relatively cheap compared to other imaging modalities, it's fairly reproducible, and I'll come on to talk about that a little bit more later on. And importantly, it doesn't involve any radiation. So in the past, there's been a reliance on mugger scans, particularly in patients who are receiving Herceptin treatment. And whilst there's a role for them, and they are good at assessing left ventricular function, a lot of these patients need to have serial scans, and what we don't want to do is give them multiple doses of radiation. So it's another advantage of echo in that it's safe from a radiation perspective. Now, in terms of if we strip cardio-oncology back to its most basic purpose, I think we can safely say that it's all about the cardiac care of cancer patients. And echo is key to so many different aspects of that. So we see patients at the beginning of their cancer journey. So before they've started any oncology treatment, we see patients to risk stratify them and detect any pre-existing cardiovascular disease. Now, of course, some patients will already know that they've got cardiovascular disease. They may have heart failure, valvular heart disease, atrial fibrillation, whatever it might be. And it's important that those patients are seen prior to commencing potentially cardiotoxic treatment so that we can optimize their management and liaise with the oncology teams to make sure that the treatment that they're going to receive is safe. And clearly, a lot of that is about assessing left ventricular function, and echo is key to that. We also screen and monitor patients during treatment, particularly during potentially cardiotoxic treatment, because we want to detect potential cardiotoxicity at a very early stage and treat it promptly so that we can minimize unnecessary treatment interruptions. Clearly, if we do detect significant cardiotoxicity, this can have an implication on further treatments. But as long as we can get in there quickly with the echo and with our treatment, hopefully we can minimize those interruptions. And then there's another group of patients who it's important we don't just cure their cancer and send them off never to be seen again. We know that there are some systemic anti-cancer treatments like anthracycline therapy that can actually cause problems many years down the line. So certain patients need to be screened using echo for long periods after they've had their cancer treatment so that we can pick up any potential late effects. Now, these guidelines are hot off the press. So these are the first European guidelines that we've had from the Society of Cardiology for cardio-oncology, and they were published just under a month ago. They were released at the ESC conference a few weeks ago. And they're a really comprehensive set of guidelines. So anyone who's particularly interested, I'd encourage you to have a look at them. And I've just picked out a few things from the guidelines that I thought were relevant to tonight's talk. So the guideline talks about the importance of baseline cardiovascular assessment in these patients. Now, I naively thought before I started my job as a cardio-oncologist, I presumed wrongly that every patient who was to receive chemotherapy would have a cardiovascular history and examination, an ECG and a blood pressure. That is not the case, and we're seeing a lot of patients who actually probably had pre-existing cardiovascular disease, but we're only picking them up when they run into problems during treatment. And the guidelines highlight how important it is to thoroughly assess patients at baseline. And this diagram here is showing you some of the potentially cardiotoxic anti-cancer therapies and what tests we should be doing according to the patient risk. I won't go into all of the ins and outs of this, because if you're particularly interested, like I say, you can have a look yourself. But you can see that echo, transthoracic echo, is advocated in virtually every single anti-cancer therapy to a greater or lesser degree. And the guidelines also talk about the importance of using echo whilst you're monitoring patients. So I've just picked out one example here, which is anthracycline chemotherapy. And the guidelines split patients into low, moderate, and high risk. And you can see there that echo is very important in all these patient groups. And the frequency of that echo monitoring changes depending on the risk of the patient. And then the guideline also talks about monitoring patients long-term. So long-term surveillance is really important. And this diagram here is talking about asymptomatic cancer survivors. So we're not talking about patients who have developed cardiotoxicity. These are patients who have never had a drop in their ejection fraction and are well at the end of their treatment. And again, according to their clinical risk, there is a big role for transthoracic echocardiography in detecting the late effects of anti-cancer therapies. So in terms of what we need to do when we do an echocardiogram, we need to be confident that an apparent decline in systolic function reflects true toxicity. As I've said, the implications for the patient in terms of potentially discontinuing cancer treatment are high. So we know that the inter and intra-observer variability of 2D ejection fraction is high. And if you measure an ejection fraction today and then you measure it again tomorrow, you could get a different result. And it doesn't mean that the patient's developed cardiotoxicity. It means that the test isn't really accurate enough. So where possible, we need to use both 2D and 3D assessment of LV ejection fraction, because we know that 3D assessment has a much lower variability. It's more reproducible and allows us to be confident that a detected decline represents true toxicity. However, it's not all about the ejection fraction. And if we wait for the ejection fraction to drop, we may well have missed the boat. So we want to detect subtle deterioration in LV function. And we know that measurement of global longitudinal strain will detect subtle early myocardial injury prior to a drop in ejection fraction, as this paper quite nicely illustrates. So you can see here your coefficient of variation looking at, sorry, I've lost my mouse, where's it gone? 2D ejection fraction, 3D, and echo GLS. And when you compare echo GLS and CMR, you can see that actually the intra and intra-observer variability is almost identical. So wherever possible, we should be using 2D, 3D, and GLS assessment in our cardio-oncology population. And this is reflected in the guideline that we released in 2021. So this was a collaborative guideline released by the British Society of Echo and the British Cardio-Oncology Society. And we wrote this because we felt that there was a need to give some really practical protocols and guidelines to not just cardiologists and oncologists, but to the physiologists. So the people at the coalface performing these scans, which, let's face it, are often really tricky patients to scan, and I'll come on to that in a little bit. We wanted to provide some clear echo protocols, some advice about standardizing the echo report, and in addition have given advice on how to get the best images, and also given ejection fraction and GLS thresholds for intervention. So like all of the other BSc guidelines, they've been released, they've been designed in the same way. So the guidelines will give you the view that you need, the measurements you need to take, and some explanatory notes, which give you a little bit of information about frame rates, ECG signals, that sort of thing. And the guidelines really emphasize the importance of accurate, reproducible assessment. Now, as I've said, cardio-oncology patients are often really challenging patients, and we need to think about what do we do if we can't see what we need to see. So we have 3 physiologists at our institution so we have about 15 physiologists, but 3 who are dedicated cardio-oncology physiologists. And we've kept it to just 3 because we felt that they really needed to build up the experience in scanning this patient group. So a lot of our patients have had recent surgery. So we see a lot of breast cancer patients. They may be in pain, they may have dressings, scar tissue, implants, they may have lines in place. They're difficult to scan. Many patients will struggle to breath hold, which is really important if you're well, in any echo, but particularly if you're doing 3D and GLS. We see a lot of arrhythmias, a lot of ectopy, which can be challenging when you're trying to get your images. I always say that physiologists and cardiologists are never happy. We're always saying that patients are too big or too small, and I think that's true with cancer patients as well. It's difficult to get between the rib spaces sometimes, and then other times you've got patients who are very deconditioned. They might be on steroids, they put on a lot of weight, and they're challenging to scan as well. There might be things in the way that make things look different, or they're not where you expect them to be. So big pericardial effusions pushing the heart, or even a tumour compressing the heart. So all of these things add up together to provide quite a challenge for the person performing the echo. So again, this was mentioned in the recent cardio-oncology guidelines, and the guidelines advocate the similar measurements and similar images to the BSE guidelines, so assessing both the left and right ventricle. But I thought it was important to mention in terms of contrast what the guidelines say, and they advocate to use contrast echo if you've got inadequate transthoracic image quality. So in terms of the use of contrast in cardio-oncology studies, I think the first thing to say is don't automatically use contrast if it's not required. So contrary to what I've just said, we do sometimes have patients who have beautiful echo images that are really reproducible, really clear endocardial border definition. And these patients do not benefit from the use of contrast. It can often muddy the waters. And if I take you back to that slide that I showed you earlier, if you look there at the temporal variability of a biplane 2D ejection fraction and then biplane with contrast, you actually can make things harder for yourself. So don't use contrast if you don't need to use it. But clearly there will be a group of patients that do need contrast assessment. So if you, in any one apical view, if you've got two contiguous segments that aren't visible, you could consider using contrast. Importantly, if you've used contrast in a previous assessment, you need to ensure that you use it for your subsequent assessments in the same patient. So what you don't want to do is use contrast one time and then 3 months later that Herceptin patient comes back and you don't use contrast, and you're a bit comparing apples with pears if you switch between using it and not using it. We don't advocate you use 3D assessment if using contrast, and I think the main reason for that is that if your pictures are bad enough to need contrast, then you're not going to have high enough quality images to get decent 3D images. And of course, there are alternatives. So I recognise that I'm quite lucky that I work in a tertiary centre with good access to cardiac MRI, and there is a role for that where there is a role for that in some patients if your echo images are poor. Okay, so I'm going to talk a little bit now about establishing a cardio-oncology service. So I started my consultant job just over 3 years ago with a remit to set up a cardio-oncology service in Liverpool. So Liverpool Heart and Chest Hospital, where I work primarily, is the tertiary cardiothoracic centre. And then 3 or 4 miles up the road is the tertiary cancer centre. And both the cardiac centre and the oncology centre work with a hub and spoke model. So there's they serve lots of university hospitals and district general hospitals around the region. Now clearly the cardio-oncology service has to be multidisciplinary and collaborative. We're making really important decisions on really complex patients, and it wouldn't be right if one person was unilaterally making those decisions. So it's really important that patients are managed across different specialties, and I think that's one of the reasons I enjoy my job so much, is I work with so many different people. So I've just listed a few here. So from the cardiac side, obviously you need cardiology input, specialist nurse input, so I work quite closely with the heart failure nurses. Obviously we need our cardiac physiologists, the oncology team, palliative care, the cancer specialist nurses and cancer pharmacists, the radiotherapists and clinical oncologists, the surgeons, primary care. All of these people are really important to running an effective cardio-oncology service. And then I think it's really important as well that you have good integration with tertiary services. So I always say to the juniors in my hospital, you know, I'm really lucky because I can phone a friend whenever I don't know what to do. So if I've got a patient with bad, you know, severe aortic stenosis, but they've got cancer, and I'm thinking I don't think that it would be appropriate for them to have open heart surgery, I've got a TAVI team I can go and speak to. We've got a dedicated cardiothoracic surgeon who comes to our MDT, who we discuss all of our patients with. We've got the interventional cardiologist who can help us with both with acute and chronic presentations of ischemic heart disease. I work very closely with our radiology colleagues, the heart failure team, and when I've got some really weird and wonderful ECGs that I can't interpret, I can go and ask the electrophysiologist what's going on. And I think it's really important that a cardio-oncology service can have access to all of this, because if you think back to the breadth of cardiotoxicity that I mentioned at the beginning, we see a lot. We see a really big spectrum of disease. It's not all LV dysfunction. So this is what our cardio-oncology service looks like at the moment. When I started 3 years ago, we had 2 clinics a month. We've now got 2.5 clinics a week, and we're about to increase to 3 clinics a week. I do a weekly ward round at Clatterbridge, which is the oncology centre, which is really useful in terms of troubleshooting cardiac issues on the oncology wards, helping with outpatient queries, and just giving a bit of support to the juniors and the consultants from an oncology perspective, because clearly their expertise is very different to mine. So it's a good way to work together. We have 3 cardio-oncology echo lists a week. We have a weekly MDT, which always has oncology, cardiology, radiology, and surgical input. We run a regional carcinoid heart disease surveillance and management program, which feeds into the regional neuroendocrine tumour service that is run out of Liverpool. We've also trained up the radiotherapists at Clatterbridge to perform their own cardiac monitoring and radiotherapy. So patients who have got pacemakers and ICDs who need radiotherapy to the left chest or breast, who may have a significant dose to the device, we've trained up the radiotherapists to do the cardiac monitoring in those patients. And we're about to start a cardiac physiologist-led echo clinic, where the physiologists are going to see the patients themselves, perform the echo, and liaise with the oncology teams rather than me needing to be involved. We are crying out for a cardio-oncology nurse specialist, so that will be our next step. And we're also setting up an immunotherapy baseline ECG review service as well, so that the ECGs performed in all of the IO patients will be reviewed by the cardiac nurses rather than the oncology nurses. So we're busy and getting busier. So if you're particularly interested in cardio-oncology, there has been a real growth in the last 10 years or so. We've got a British Cardio-Oncology Society, an International Cardio-Oncology Society, and an ESC Council of Cardio-Oncology. And like I say, the guidelines that were released just last month are freely available online if you're particularly interested in this area and want to learn a little bit more about it. That's a good place to start. So in conclusion, demand for cardio-oncology services is only going to grow. So we know, as I said at the beginning, the incidence of cancer is increasing, survival from cancer is increasing. We've got a growing patient population who may require our input and help. And I hope I've convinced you that your role in this, so the role of of echo, is pivotal to decision making in cardio-oncology, because it makes such a difference to treatment planning and potential adjustments of treatment. And like I said, it's really important that we have high quality, accurate, reproducible echo assessment in this patient group. And that is the end of my talk. So I will hand back over to Jerome and just stop sharing.
Thank you very much, Dr. Dobson. It was very clear and I think also very convincing talk. There's a question. It's on the frequency of echoes. It's from Paul Nolan, who says most oncology patients appear to get echoes every 3 months. One of your slides implies new guidelines have longer intervals between echoes based on risk. If I am right, how do we inform the oncology community?
So the frequency, if he's talking about Herceptin, the frequency depends on whether you're receiving Herceptin in a metastatic or non-metastatic setting. So if you've got non-metastatic breast cancer, which is HER2 positive, and you're having Herceptin, you'd normally have it for 18 cycles. And in that patient group, the guidelines advocate that patients should be screened every 3 months. If it's in the metastatic setting, you would continue Herceptin in this patient group until they stop responding. So some patients with metastatic breast cancer will have Herceptin for years and years and years. And we know that if you're going to develop cardiotoxicity, you're far more likely to develop it earlier on when you first receive your Herceptin. So the guidelines advocate scanning those patients roughly every 6 months. Now, if you read 10 different guidelines, you'll get 10 different timelines of surveillance. And I don't think anyone can say with any huge bulk of evidence behind them, yes, you absolutely need to do it at 3 months or 6 months. And I think sometimes we have to be a bit pragmatic. I'm aware that certain centres they can't keep up with the 3 monthly echoes, so they're done at a 4 monthly timeline. But usually the oncologists will liaise with cardiology to come up with a plan for that.
Thank you. Now, a question from Robbie Cajol, who's asking, was GLS, do you use peak systolic strain or end systolic strain?
Peak systolic strain.
Okay. Thank you. And Costas says, thanks you very much for your useful talk. If you do not have good windows for 3D left ventricular ejection fraction, would you recommend CMR or compromise on 2D LVF? Alone in respective of GLS? So
if it depends. If you've got really poor echo windows, I did a clinic yesterday and I had one patient who, no matter what we did, we couldn't see a thing. And she just didn't have any echo windows at all. And I had no confidence in interpreting her LV or assessing her LV function. So for her, she needs a CMR. If you've got someone who's got decent windows and actually you're quite confident that you've got a good 2D ejection fraction, I wouldn't automatically then go on and get an MRI just because I couldn't get GLS or 3D. Because remember, certain centres or some centres don't have access to 3D and GLS. So I think it's one of these things that we should be doing if it's technically feasible and if you've got the resources to do it, but it's certainly not something that if you can't do, everyone should be having a CMR.
Thank you. Another question from Gary. What would your approach be to a patient who had significant drop in GLS with normal ejection fraction? Do you think the evidence is there for cardioprotective therapy in these patients?
Okay, so this was a trial. There was a trial who tried to address this that was published last year, I think, the SECURE trial. So we were all sort of waiting with bated breath for this trial to be, the results to be released. And what they did was compare a GLS guided strategy versus an ejection fraction guided strategy in patients with who were receiving anthracyclines and or Herceptin. And they didn't actually meet the primary endpoint. So the patients who they put on cardioprotective therapy based on a drop in GLS, but at the end of the study, there was no significant difference in one, cardiotoxicity, drop in ejection fraction, or interruptions to cancer therapy. So it was a very contentious study with lots of people disagreeing about what the results meant. And I think normally when everyone disagrees, it means that we need another study. So there is no strong body of evidence for cardioprotective patients based on a drop in GLS with a normal ejection fraction. However, in my clinical practice, if I get a drop in if I can see a drop in GLS with a normal ejection fraction, it highlights to me that I need to keep a closer eye on the patient. If I'm confident in my echo findings, it normally makes me think, right, I need to bring them back a bit sooner and recheck them. And depending on their blood pressure, depending on their cardiovascular risk profile, I may well commence cardioprotective therapy with not very much evidence, but I would never stop cancer therapy based on a drop in GLS alone, because the evidence just isn't there.
Okay, thank you. Another question, burning question from Mahmoud Raslan. Any change in recent guidelines regarding definition of LV dysfunction related to cancer treatment in form EF and GLS?
Well, like I say, all guidelines, you read 10 guidelines, you'll get 10 different definitions. So the definition that we used in our BSE guideline is one of the most commonly used. So we defined cardiotoxicity in terms of ejection fraction drop as a change of more than 10 percentage points to a number less than 50%. Now, it's important, because I used to get confused about this as well, because my maths isn't very good, but when we're talking about drop in ejection fraction, we're talking about percentage points. When we're talking about a change in GLS, we're talking about percentage change, and they're two different things. So if you get someone with a change in GLS from -22 to -18, that's 4 percentage points, but it's a 22% drop, and clearly that would be significant. So when you're reading the definitions, just make sure you understand exactly what that particular guideline is saying. But I don't think there's been any significant change in the definitions in the new ESC guidelines, no.
Okay, very clear. I think if you have other questions, we still have the Q&A session at the end of the talks. So if you think about a question, we can address it afterwards.